In this talk, I'm going to talk about computer-aided endoscopic diagnostic system for bladder cancer. And bladder cancer, it's a common malignancy. And most of the time, the first-line treatment will be transurethral resection. And most patients have non-muscle invasive bladder cancer, which means that a good transurethral surgery should be curative. But unfortunately, we're still seeing a very high recurrence rate of up to 50, 60%, in particular for high-risk cases. And we really need to think, why is that the case? What are the underlying reasons for that? One of the possible reason is about the bladder cancer detection part, because sometimes the tumor may be subtle and they may be prone to a missed diagnosis. And also, when we see tumors inside the bladder, we try to finish the surgery quickly, but at the same time, we may overlook cancers which are very subtle in terms of its visibility. And so this is just one of the examples where we can try to enhance the detection. So the CROWS group has conducted a clinical trial on the use of narrowband imaging. And I just want to point out to you one of the findings for low-risk non-muscle invasive bladder cancer. They found that the one-year recurrence rate in the NBI group is much lower than the white light group. It's about 5.6% versus 27.3%. But what I want to highlight here is actually the 27.3% here, because it's actually very, very high for a genuine low-risk cancer. So it's even higher than their own intermediate risk cancer group. So there is a big argument whether these are genuinely low-risk cancers or whether simply because we missed those tumors at the very beginning. Therefore, there's really a need for a better detection. And I'm going to talk about this system here because I really think a computer-aided system or artificial intelligence or deep learning system can really help facilitate the detection in terms of speed, in terms of accuracy as well. And since this is an innovation session where we wish to share how we develop these things, so I want to talk about this in a step-by-step manner. In order to develop this system, there are several crucial steps. First, you need to have a question, you need to have a database, you need to have enough data before you can talk about training up the system. And sometimes the data being collected is quite crude. You need to normalize the data in order for the computer to interpret it correctly. And of course, for every scenario, there's a subject of interest. In this particular case will be the bladder tumor. So you need to have a manual annotation of the tumor on the images, and then you need to develop an algorithm for the deep learning part. And then once you have done all these, the later part is actually easy. Once you have enough data, you need to train it, you need to validate it, and you want to test it to see whether your system really works or not. So database collection, of course, at the end of the day, we want to have videos. But then to begin with, we start with something simpler. So we need to have a lot of images. Both normal and abnormal images are needed because you need to train up the system to recognize what is normal and abnormal. And then because your images can come from different systems, and it can come from rigid cystoscope, it can come from flexible scope. So the images by themselves can look quite different. So you need to somehow do some pre-processing to normalize it in terms of its size, normalize it in terms of the area that you want to look into before you actually feed into the system. Subsequently, this is the most time-consuming part. You need to set a reference for the computer to learn. So in this particular case, then we need to mark the visible tumor one by one, or any abnormal areas one by one. So this is what we call annotation. It can be annotation on anything abnormal here. And then subsequently, you want to develop an algorithm. Of course, there are many different ways of doing it. In our way, it's relatively simple. We use a segmenter to segment the different regions at pixel level. But more importantly, we want the computer to identify whether they look like to be cancer or it's just a normal variant. And then these are just some preliminary results of how it would look like. So you can see on your left, the most left column is a ground truth. It's something that we've marked by ourselves. The white thing is what we've marked. The middle part is what the computer has identified as abnormal. And then the third column is the real image that we're looking into. So you can see there's a considerable overlapping of the ground truth and the prediction. So it's relatively reliable in this sense. So actually the green rectangle will be denoting the ground truth area. The blue rectangle will be what the computer has identified. So similarly on the right here, then you can see a very similar figure, ground truth prediction, as well as the real endoscopic figure. And then if you look more carefully, there's a red figure there, which is the prediction. 1.0 meaning 100%. If the computer thinks this is likely to be a malignant cancer. But then there will be scenarios where they will give, for example, 85% chance, 90% chance. It really depends on how they think the images relate to the final histology. And this is something that we need to feed in the system as well. And to train up this system, we used more than 100 patients' videos, images. Altogether, we have more than 4,000 images in this training set. And then preliminary, we are able to achieve sensitivity of about 80%, specificity of about 90%, resulting in an area under curve of 90.6%. I would say this is something promising, but it's not ideal. So it's just a preliminary phase where we started, but then we still need a lot more images training in order to improve this. We have actually collected more than 10. Sensitivity is about 86, 87%. Area under curve is about 92 to 93%, but we're still finalizing data, so I didn't present it here. Next step, we need to optimize the diagnostic performance. And then we need to have a real-time transmission between the endoscopy system as well as the deep learning system. This is extremely crucial because you want the system to really tell you at that particular moment when you're doing the cystoscopy. And then we need a very friendly user interface in order to facilitate the application. And of course, you need more prospective clinical trial to really investigate its value in our clinical practice. Just to let you know some of my thoughts, I previously wrote an editorial on artificial intelligence at BJUI. I think artificial intelligence is really the way to go. It might take some time, but it's really the way to go. AlphaGo is a very good example. It basically outperforms the human in the most complicated game. And to take one step further, AlphaGo Zero actually defeated AlphaGo by 100 to 0. So you can, it's really exciting and even shocking to see what AI can really achieve. But at the same time, there are a few things that we need to overcome, including understand how it actually works, because now it's still like a black box. How it recognizes the best decision is really something that needs to be understood. And then we still need a lot of regulation standards in order to facilitate application in healthcare. Hopefully, at the end of the day, we really wish to utilize AI in a complementary rather than a competitive manner. So hopefully humans and computers can work together in order to benefit patient care at the end of the day. So I would like to end my presentation here. Thank you once again for the opportunity. And of course, I will welcome any questions. Thank you very much.
Wonderful. I think Jeremy, you put it's a bullseye. Basically, I think your last statement makes the greatest sense of all. You work together and makes it better, and you will be able to you'll be able to give the better results. At present, the data, what we are able to process, the data collection is still happening and still happening and still happening, and there is no end to it. I think as the data goes on adding, the results might be changing to certain extent, and they get tweaked over a period of time. So what looks correct today might not be correct tomorrow. By 5 years down the lane, it may change itself in its own way. I think, but well, that is a way to go about, and possibly that is how the human error can be nullified to a certain extent. What do you say, Aditya? Unmute yourself.
Am I audible?
Yep, of course.
Yeah, Jeremy, I was very intrigued by your presentation. Two quick thoughts came to mind. The first was that what is the endpoint of this kind of an AI application? It seems to be that if I am able to put in a cystoscope, get these images onto your program, and then the program gives me an output that this is high grade or this is low grade, or in the neighboring areas there is CIS, that would be the culmination of such a program where I obviate the need for a biopsy and histology. What is your perceived endpoint of this application, Jeremy?
So you're right. So ideally, it's a system that is applicable real time. That is when you are doing cystoscopy, when the system really identifies an area that is abnormal, then the rectangle will appear. So it tells you that where is the possible abnormal area. So you need to focus on the area, and then you can possibly do biopsy or resection of the area. So at the end of the day, you want to enhance the bladder cancer detection. You don't want to miss anything, and hopefully reduce the recurrence rate.
Excellent, excellent. The other small question here is that the whole accuracy has already reached, you said, of sensitivity is considered very high. What were your problem areas where you had false negative and positives?
So I think the performance, it's okay. At least at the beginning, it's a good start. But I really wish to optimize it further. At the end of the day, the biggest problem is missing a malignant tissue. So the sensitivity needs to be very, very high in order to avoid missing a tumor.
Yes.
But at the same time, you might risk a lowering of the specificity as well, because when you detect more, then you detect something that might not be tumors. So this part is a tricky part that we're trying to work on.
Excellent. Are there any other questions on the panel?
No, I think as the data goes on adding, the variations will start happening. I don't think there is any endpoint for this on any day. The endpoint today might not be true tomorrow. And will this techno replace the surgeon on site tomorrow? Some technician like an echocardiogram, somebody puts a cystoscopy, goes across and comes out, and the computer will tell whether you have a bladder tumor or not. What do you say, Jimmy? This is the last question, and we'll go to the next.
That is actually what I'm trying to point out at the last slide. I don't think humans and computers should be competitive. We should work in a complementary manner in order to improve the patient care. So a simple answer, no, it won't replace us. We should make it help us in our clinical.
I think that's a final point of an answer.